Prof Chng is the next speaker. He will speak to us on the need for treatment on M proteins. Thank you, Prof Chng.
Okay, great. That was an excellent presentation by Dr. Mauli there that hopefully set the stage and provide very useful. I thought the videos were very kind of nice as well because it showed very graphically some of these very complicated concepts that we try to explain in the clinic, not very successfully usually because they're quite complicated. I thought that was useful. I think I want to address this issue that very often the patients come to clinic and they ask, both those patients that come in where they were found through usually screening, nowadays, which is a good thing. I mean, people go and have regular screening blood tests, and sometimes the GP are quite vigilant. They find out that, the protein level is increased, and then they do further testing, and it's found that you have this monoclonal protein or M protein that is detected in the blood. And so they will refer you to a specialist, right? So that's one category of patients that come in, they're completely well, and to them it's a shock. It's like, whoa, what's going on with this abnormal results? I'm very worried. And then the question is, do we need to start treatment, right? Someone is telling me I've got abnormal protein, abnormal cells in me. Do I need to start treatment? Then the other big group of patients are those that actually have a diagnosis of myeloma. They have undergone treatment. Okay, and the treatment has made them feel better. They're feeling back to normal. They are wanting to go back to work. They're going back to doing their sports and whatever as per usual. But then the M protein either cannot completely disappear. Okay, so there's a bit left, or it has disappeared. So the patient has gone into a remission. But after a while, it's kind of reappeared a bit again, at low levels, right? So then the big question here is that, do I need to start treatment again? When do I need to start treatment? Why am I not having treatment? The worst thing is, not the worst thing, but sometimes in the patient discussion, there's always comparison. Hey, how come you're on treatment and I'm not? I'm having this M protein, So, there's a lot of confusion and a lot of concern, naturally, right? So I thought I'll address this issue and hopefully later on we can have a discussion as well to try to clarify some of these points, right? The first thing to say is that M proteins are very common as you get older in normal population, okay? It goes from 3 to 4% of everyone above 50 to 5% if you're above 65, to 10% if you're above 85, right? So 10% of people above 85 who don't have myeloma or any plasma cell related problem may have M protein that is present. And in fact, in a study, this is quite old now, from the Mayo Clinic of more than 1,000 patients, they found that the causes of presence of M protein, only 18% is due to myeloma. The rest are due to, other kind of conditions, right? Including lymphoma, as well as, some rare types of lymphoma like Waldenstrom's, amyloidosis. These are also constituting about 17-18%, about the same as myeloma. And then the big, huge number of these are what we call MGUS, or the monoclonal gammopathy of undetermined significance, or those old people that have M protein but is completely well, no symptoms, right? So the definition of this is you have M protein, but you have no symptoms, and this M protein is of small amount. Or you have smoldering myeloma, which is now a higher level of M protein, but still the patients don't have any symptoms, okay? So the question is, are these MGUS patients, are these smoldering myeloma patient, what are they? What are they? How do they behave? Do we need to treat them? Okay? So first thing to say is that we have some criteria to classify the patients into these categories. Monoclonal gammopathy of uncertain significance or undetermined significance, MGUS, smoldering myeloma, and symptomatic myeloma. These patients need treatment, no questions. Okay, they have symptoms, and what are these symptoms? These are the crab symptoms. We call crab, easy for Singaporeans to remember. We like our chili crab, pepper crab, and all those. Crab stands for high calcium, that's a C. R is the renal impairment, high creatinine. A is the anemia. and B is the bone disease. So if you have any one of these symptoms, right, together with the M protein, you have myeloma, you need treatment. So these guys don't have any symptoms or what we call end organ damage, nothing at all, and they feel fine. But they have M protein, right? And depending on whether the M protein is above or below this magic mark of 30 gram per liter, you're either MGUS or myeloma. And then also they look at the bone marrow plasma cell percentage. So if you have less than 10%, you are MGUS. Okay, so we have a way to classify these things. Okay, and why is it important to classify them? Because if you look at this MGUS, right, and this has been a very painstaking studies, looking at patients over 25 years in Minnesota County, where it's governed or covered by the Mayo Clinic. So this is Robert Carl's lifetime's work. They see that the patients that have MGUS, the progression to myeloma is really almost like a straight line. And it's like 1% per year, okay? So your risk, the first year you have myeloma is only 1%. The second year the first year you have MGUS is 1%. Second year you have MGUS is 2%, 3%, 4%, 5%. So if you live 100 years with MGUS, you have 100% chance of developing myeloma. But who lives for 100 years with MGUS, right? Because you're probably diagnosed with MGUS in your 50s or 60s. So that is impossible, right? So, but the progression is really very low risk, very little, right? So these patients do not need treatment, because if you treat them, it doesn't really help them, because they may not develop myeloma in the first place. And the chances is they will not, because the risk of developing myeloma is very low. So what these people need is follow-up, right? So they need to be followed, initially maybe every 6 months, and if they are stable, they can follow over a longer period of time. And if they develop new symptoms, like if they become anemic or whatever, reevaluate again whether these symptoms are due to the plasma cell or something else, because there could be some other reasons for some of these things, like kidney problem and so on, right? So these patients don't need treatment. Okay, so if you have an M protein and your doctor tells you that, oh, actually you've got MGUS, you don't need treatment. But you do need monitoring. You need follow-up. Okay, so that's the thing about patients with M protein, is that they do need to go back to your specialist on a regular basis for follow-up, because we must monitor and see whether your M protein will increase and then you develop symptoms or not. So you cannot stop going back to the doctors. But the follow-up frequency do not need to be very high. It's not like you need to go back every month or every 2 months. It could be much longer than that. Okay, and then if you have a higher risk MGUS, so there are ways to look at it using some of the blood parameters, then we may need a closer follow-up, right? Closer follow-up, rather than 2-3 years annually, right, for life. Okay, so it's just how much follow-up you need. And if there are other suspicious things, like if you've got some other symptoms like lymph node or lymph gland swelling, then we need to look for lymphoma. Okay, other causes of abnormal M protein. Okay, so it's quite clear that for MGUS, you don't need any kind of treatment, but you need follow-up, and the frequency of follow-up depends on the risk that is based on some blood parameters or blood tests that your doctors will do for you. The other category, if you remember, next step up is called the smoldering myeloma, right? Smoldering myeloma, where the M protein is higher, or the plasma cells in the bone marrow is higher percentage, but you still don't have symptoms, perfectly okay. Right? Now this one, again, Bob Carl's work over 25 years in Minnesota looking at these patients, the risk now is quite different, you realize? This is MGUS, is like at this kind of rate, very flat, very low. The smoldering, chances of progression is much higher now. And there are this group here that progress very fast, right, to myeloma. Within 5 years, there's 10% of these that will progress. But those that don't progress within this time, it becomes flatter and flatter. And there's a large group here that behave almost exactly like your MGUS. So the key thing now is, can we identify this group of patients? Better still, can we identify those that are here that progress within 1 or 2 years, because these patients may be the ones that we need to treat earlier before they develop symptoms. And it's worthwhile treating these patients because they are almost certainly going to be developing myeloma within 1 or 2 years, right? So this is the group that we are looking at, that potentially we may need treatment. So how do we identify this group? Is there some ways for us to identify this group of patients that may require treatment earlier? And luckily the answer is yes. Through many groups' excellent work, they identify some important parameters through the studies of these patients. So here is a study where clearly if you have a bone marrow plasma cell percentage of more than or equals to 60%, that means when we do a bone marrow and we look under the microscope, there's more than 60% plasma cells inside the bone marrow, your risk of progression to myeloma is almost 90% or more within the 2 years. And in fact, 50% of those patients would have progressed within 1 year. Okay, so this is a very high-risk group. So that's one parameter. Compared to those that have less than 60%, these guys are doing a lot better, and their progression, hasn't been reached in the median, or maybe it's about 10 years. So this group may not need early treatment, but this group need. The other one is a free light chain ratio of 100. Okay, and you can see here these groups progress much faster at a median of 15 months. So again, within 2 years. So those are the group of patients that we want to target. Within 2 years, they get progression. So this is another criteria, free light chain ratio. Okay, and then this group from Greece nicely look at all these parameters and again identify these two parameters, free light chain ratio and bone marrow infiltration, as important. And they even show that if you have both this together, your progression is only 8 months. So very, very high risk. Okay, so these are the parameters that we can use. And the third is that if you have smoldering myeloma and you did an MRI whole body and we are able to detect more than one or more focal lesion on your MRI scan in your bone, your risk of progression is only about a year. So again, able to identify a very high-risk group of patients. Okay, so using the bone marrow plasma cell percentage, the free light chain ratio, and the MRI of your bone, these three parameters, we can identify a high-risk group of smoldering myeloma patient where the time to progression to symptomatic myeloma, to develop symptoms, is only within 2 years. And these are what people today call early myeloma. So these are perhaps the group of patients that need early treatment, okay, or that early treatment may benefit them. So that's the group. And then you have the low-risk ones, which are more like your MGUS. Look at these guys, hardly any change at all in terms of progression, almost a flat line, that you can monitor them like your MGUS patient, once every 6 months, and then after that, once every year or once every 2 years. Right? And then there's this group of standard risk that is in the middle that perhaps need closer follow-up because they may progress after 5 years, after 6 years, and you need closer follow-up. Then the question is that, okay, good, you can identify these early myeloma patients, right? High risk for progression. Do they really need earlier treatment? Because does it benefit the patient? Let's give them maybe 2 years time. If they develop the symptoms, we treat them just like how we treat myeloma. They get 2 years off treatment and they may have less symptoms from the side effects of the drug. And who knows, they may progress after 2 years because that's also just an average. It's not 100% of patients progress within 2 years, right? So do they benefit from earlier treatment? Now we get a sense that they do potentially benefit from earlier treatment from this study that was published in New England a few years ago already. There are now many trials that are testing early treatment in this group of patients to see whether they benefit. And I think in the next 1 or 2 years, a lot more information will become available to tell us whether early treatment definitely helps patient or not, and also what type of drugs would be most useful for early treatments. So this trial, they use Lenalidomide, I think this should be very familiar with many of you. Many of you may have treatment with lenalidomide before. The reason why they use this drug first is because it is an oral medication. It's quite convenient for patient to take. And also at that time, this is probably one of the better oral medication that we have. So they wanted to test this in this trial. And so this is the design. They test this drug together with dexamethasone for 9 cycles, followed by just lenalidomide maintenance alone, compared to the other arm, the so-called control arm, which is no treatment. Because at that time, the standard is not to give treatment, right? So they're comparing against a standard clinical practice. And I think when the trial started, many people would think that surely yes, when you have treatment, you will delay the time to progression. That's only logical and natural, right? So if we see that, it wouldn't be surprising. But people half suspected that it wouldn't change the overall survival. So whether you treat early or you treat them later when they develop symptoms, the overall survival may not change, if it's not beneficial. And most people think that it will not change. But the surprising thing is that you can see clearly here that the lenalidomide dexamethasone patients have much longer survival. And so it would appear that early treatment, at least in this one trial, with lenalidomide and dexamethasone benefit patient with high-risk smoldering myeloma disease. That's one piece of evidence. We have to, if you're a bit more conservative, you would want to wait for another 1 or 2 trials to confirm this concept. But if you are very kind of aggressive type individual, you want to go for the best possible treatment, even if there is some small chance that it is true, then you would say I want treatment when I have high-risk disease. So I think on me, I usually talk to patients and see what's their appetite for treatment versus toxicity versus benefit is before we decide, because there's one evidence. If there's more, then it becomes standard, then I will say that we probably should treat early. But if it's one, we can have a discussion knowing what the appetite is. But as a result of that, now you can see, right? So if you have smoldering myeloma, no symptoms, but you have more than 10% or more than 30 grams, this is smoldering myeloma. We will look at 3 other parameters. Is the plasma cell percentage more than 60%? Is the free light chain ratio more than 100? Is the MRI more than 1 focal lesion? If it's yes, it becomes what we call now today active myeloma, and we should treat. In my case, as I said, I'll have a discussion with the patient. If you are no, then it's smoldering, then you observe. And if you have MGUS, you observe as well, right? So this answers the question, what happens if I have M protein and I'm well? After I go to my GP for a screening test, this is what they tell me. I've got M protein, I need to go and see a blood specialist, but I feel well, I have nothing. So do I need treatment? This is telling us what to do. Okay, so if you have smoldering, you have MGUS, no need treatment at all. It's very safe. If you have smoldering, you look at these criteria. If they do have these criteria, you should consider treatment. But you can also wait a bit and see what's happening with the M protein, because very often we get only one single reading at the beginning, right? That patient could well have that reading for 3-4 years before that. We don't know. It's just that he never go for screening before, right? Or the GP never pick it up. So you must imagine that this thing doesn't just appear overnight. It's not like today I wake up, suddenly got M protein. They take time to build up, right? So sometimes it may be also sensible, if you're completely well, to just get a few other readings over the next couple of months to see whether this thing changes at all or they remain stable. Okay, and certainly in recent months and weeks, I've had a few patients that's like that. We have monitored. There are some patients that remain no problem, and they have remained no problem for a number of years. But there are other patients that within 6 months, it's quite clear that they're progressing, and we have to start treatment earlier. So the tempo of the progression is also an important factor. It's this pattern, okay? So then the other group is what happens if my M-band reappear or start to rise after I finish my treatment? I'm so happy now I finished my transplant and all those things. The doctor tell me everything is clear, I'm going back to doing my routine. And then, 1 year later, at one of the clinic appointments, they tell me that it's come back again, so do I need to start treatment? And again, this is it's highly variable. It depends on many, many parameters, which I'll explain a bit later. But first of all, what is constituting a progression is that very often when you just have after treatment, your M band disappear, right? So the doctor tells you everything disappeared. There's no more protein, there's no more band. If it then later on the band just reappear, but still they cannot measure the protein or the protein is very low, it doesn't really constitute a progression yet. There needs to be some criteria. There must be a 25% increase in the protein or the light chain on 2 consecutive occasions compared to your lowest point. But there also need to be an absolute increase by 5 gram per liter or light chain by 100 gram per liter. So there need to be some real increase, not just some little reappearance. All right? And then there are 2 scenarios that you can see in the relapse setting clinically, right? One is what we call a slow asymptomatic relapse, or sometimes we call a biochemical relapse, because the only relapse is seen in the blood test. Okay, the patient really doesn't have anything. Okay, they don't have any symptoms. The rise in the M band is very, very slow, and I'll show you some example of that. The tumor burden is low. There is no plasmacytoma that's growing out of them. There's hardly any kind of bone disease. The patients may have low-risk disease, as explained by Dr. Mowley before, based on the genetics and stuff. Okay, so even at the beginning, they were low-risk disease. They responded very easily and very well to treatment. So these are the good type of patients, and then they have good performance status. They're fit. They don't have many organs that is already affected by the myeloma. When they presented, they didn't have renal failure or vertebral collapse, that causes cord compression. So they presented maybe with just some anemia, fatigue, and so on. So they have overall, the presentation was good and the performance status, they are fit and well. Okay, so these patients we can afford to observe a bit and see again what is the tempo of this rise in the M protein. Okay, and sometimes they can take a long time, and even when they rise, they can stop, and then it remains like that for a long time. Okay, and I'll show you some example later. The other clear scenario is the fast symptomatic relapse. They come in, straight away they have symptoms already. You can see the blood count is falling. The creatinine is going up, suggesting that kidney is affected, right? The M band rise 2 times. Every month you see them, they go from 2 to 4 to 8 to 16 every month, right? It's very fast. They may present with extramedullary disease, or initially when they presented, they have a lot of bad symptoms, right? They needed dialysis, they have transfusion requirements, they have plasmacytoma. So it's a very aggressive type of presentation. Then you need to act a bit faster, organ involvement. They have high-risk disease, and they're already poor performance status, meaning that they may be a bit more elderly, they may be having other issues, medical problem. Then these guys needs very prompt treatment. Of course, as always, there are also a big group that is in between. They could be asymptomatic, but they have organ involvement, high-risk disease when they started. These patients, again, you want to monitor. Even if you don't want to start treatment straight away, you want to monitor them very closely, and at any signs that there is increase in the M band, upward trend, you may want to treat them before they develop symptoms as well. Right, so there is 3 categories really. This one, don't wait, start straight away. This one, you can monitor for longer. And then in the middle, closer monitoring and start treatment early if any signs of progression before they develop symptoms. Okay, so that is what I will usually do and I'll recommend to the patient. So I will show you 3 examples of patients that I've seen in clinic. So this is a patient who have myeloma that was treated here and did very well. You notice that the patient is not in complete remission. Even when we say very well, he still have about 3 grams per liter of monoclonal protein. thing to say is not every patient is able to go down to zero. Okay, not every patient is able to go down to zero. These patients, after we have had transplant and all the other treatment, went down to this level. Okay, and we decided to stop the treatment because he had side effects, toxicity from the ongoing maintenance and so on, so we stopped that. And we monitor the patient. So after stopping, you realize that yes, the M protein has gone up a bit. The time frame here, this is in the order of every 2 months. And here, because it's going up, I say we monitor you closely once a month. But you can see that the rise, is not very fast. This is 6.2, 6.5, 6.7. So it's very little change. And it also fluctuates, right? So if you draw an average, it's actually probably around here at this stage over a period of 6 months, right? And the good thing is the patient is completely asymptomatic. He's back at work. He doesn't have any problem with anemia. Creatinine was okay. Calcium level was okay and all those things. And we continue to watch him, right? And then you can see that over time, and this is over a period of 3 years, it's kind of gradually went up to now 14. You would say that it's gone up how many? 7 times compared to its lowest point, okay? But its lowest point, is not 0. So this is 2.9 up to now, 3 years. He still remains well, completely asymptomatic, off treatment, and pretty happy. So I'm telling you these alternatives that there are patients that you can monitor. He has low-risk disease when he started. There's no major organ involvement. He's relatively fit still, and this is him. I can tell you that at some point, if these things continue to go up, he will develop some symptoms. At some point along this trajectory, we may well need to start treatment. But if I had started treatment here, I would have given him 3 more years of treatment when he may not have needed, 3 more years of potential side effects from drugs, and 3 more years of cost of treatment. So this is just to say that we need to look at not just the M protein itself. We need to look at the whole package, including the blood count, the creatinine, the tempo, the patient's presentation, the disease. So work with your physicians in kind of identifying the right approach. We also have another patient here that, again, have myeloma, was treated very nicely, went on to a clinical trial after the transplant for maintenance treatment, and it worked for a while, but then it started to come up. At some point here, the patients officially, based on criteria, considered to have progression, so have to stop the trial. So no more drugs, right? No more drugs. But he was getting, again, a bit of side effects from the drugs, and he was kind of thankful to have this drug-free holiday. He said that, fine, stop the drug and let's see what happens. He didn't want to change treatment to another treatment straight away because he was having some side effects from the treatment, right? So we can see here, he continued to progress, right? I mean, the reading continued to creep up. This is a light chain reading, creep up, and then here there's a little jump here. But throughout this time, he was completely, again, asymptomatic. His blood count is normal, kidney normal, calcium normal, no bone pain at all, becoming more active. Actually, he was quite thankful not to be on treatment and having a treatment-free period. So for this patient, I will continue to not give him treatment, just to monitor him over a long period of time, see what is happening with this trend. Is it going up more like that now, or it will stabilize and become more like that, right? Before we decide. So sometimes it's not necessary to jump in. Patients can do pretty well still when they have so-called progression. This is another patient. The reading is very high now, right? This patient's reading is like 30-something, M band 38, highest at some point. He was, again, a patient who was on a trial. After transplant, went on to a maintenance study, was on a maintenance for a period of time, and then progressed on that. I think this is the point where he progressed. So this is the baseline at the point that he stopped treatment. I look at this level and I said that, well, maybe you should consider going on to another treatment because it looks a bit high. Because one of the common questions is patient asks, how high would you go before you start treatment, right? So the level itself may not be the absolute requirement as well. So, but he again, sometimes what patient one, is valuable, because he said that, well, I feel perfectly fine, right? And I, was having, again, some side effects on these treatment that I had before. I would, again, rather not have treatment. Can we monitor and see? So I said, that's fine, let's monitor closely. And because he was on a trial follow-up, even though he stopped the drug, we are seeing him every month. Okay, I say, then let's monitor. So he has been coming back every month for follow-up since stopping the trial drug, but he's still on survival follow-up for the trial. You can see that, first of all, it didn't change much for a number of months. Then it had a bit of a jump. This is 29 compared to 25. Okay, so this jump is about 18%, okay, up from this level. And then it fluctuates, and then it went up, and then it fluctuates around some sort of baseline, then it went up a bit as well. So now it's 38. Okay, it seems quite high, but the patient continued to be well, full blood count normal, creatinine normal, and so on. So I'm just trying to paint a picture that when you have emergence of M protein or rising M protein, it doesn't always mean that I have to start treatment. Of course, the patient have a choice. If you are uncomfortable with that, we can treat you, that's not a problem. But not everyone need treatment straight away. And I usually would like to monitor things for a period of time, particularly if they have low-risk disease. They come from a background where their presentation was nothing serious, no organ damage. Their blood count remains completely normal. And we can monitor and look at whether there's any emergence of symptoms. And sometimes you don't need to wait until the symptoms emerge, because you can look at the trend of the creatinine as well. If the creatinine is creeping up, although it may still be in the normal level, it may be a sign that something is happening. If the hemoglobin for the patient is normally 13 and is coming out to 12, coming down to 11, these are still fairly normal levels, but you know that something is happening, then you can start treatment earlier. But if they remain flat, 13, 14, very robust for hemoglobin, creatinine is completely normal, and everything else is normal, and the kind of tempo of these changes are not kind of going straight up like that, but is more like this and is pretty flat, we can sometimes monitor the patients. But the key thing is the patients need to be monitored. So the patients cannot think that, oh, I don't need treatment, great, I'm not going to come back. They need to be monitored, because at some point they truly will need treatment. Right? So I think in conclusion, treatment is not always necessary with the presence of M protein, as we saw at the beginning. MGUS just need follow-up. Smoldering, again, if they don't have high risk, don't need early treatment. If they have high risk, there are data that suggests early treatment may benefit, but that's one trial. I'm usually having a discussion with the patients to see their appetite for treatment versus side effects versus benefit. And then if they have relapse, again, it doesn't necessarily means you have to have treatment. Depends on these things: the tempo of change, the presence of symptoms, evidence of significant tumor burden at the beginning of the disease, whether they have a lot of kind of organ involvement, and then also what is their risk, and also how did they present with their disease. Okay, so these things requires clinical judgment. So clearly have a discussion with your physicians when you are in this situation, and then together reach a strategy on what to do with the disease. Okay, so that's the end of my presentation. I think we better move on, right? Thank you.
Thank you, Prof Chng.